Your eyes and your vision are under attack. Damaging blue light from the sun, your phone, your computer, your tablet, even light bulbs and car headlights is constantly bombarding you. The good news is our eyes actually already have a line of defense to counter the effects of blue light. This defense is made up of 3 pigments called carotenoids. MacuHealth with Micromicelle, the only supplement with the exclusive patent on all 3 macular carotenoids and Micromicelle technology.
Do your patients know what presbyopia is?
There are people who are afraid of the press.
Have you talked to your patients about multifocal contact lenses?
I've heard the bifocal, but not multifocal.
Exactly, not multifocal.
Do you need help with your multifocal strategy? Learn more at the conclusion of this episode. With more screen usage and indoor time, myopia, also known as nearsightedness, is increasing and getting worse in children. Now, certified eye doctors can prescribe MiSight One Day, the first and only FDA-approved soft contact lens to slow myopia progression in age-appropriate children. Visit CooperVision.com to find a Brilliant Futures certified eye doctor near you. Hello and welcome to the Open Your Eyes podcast. I'm Dr. Kerry Gelb, the host of the documentary Open Your Eyes. If you're new here and you like our interviews, press like, subscribe, share, and hit the bell to get notifications of great new interviews. Also, please leave comments. Great news, you can now watch our full-length documentary Open Your Eyes on Amazon Prime, Apple TV, iTunes, Google Play, and YouTube movies and shows. Glaucoma is the leading cause of irreversible blindness worldwide, and the prevalence is increasing. Glaucoma accounts for an estimated 10% of all the blindness in the United States. Elevated intraocular pressure is recognized as a major risk factor for the development and progression of glaucoma, and lowering IOP or intraocular pressure is currently the only documented method of treating glaucoma. Today's guest, Connecticut glaucoma specialist, Dr. Francis Falck, Ph.D., M.D. Dr. Falck is a surgeon, researcher, lecturer, and inventor. Dr. Falck's invention, the FMD, Falck multifunction device, has multiple glaucoma diagnostic functions with the goal to revolutionize the diagnosis and treatment of glaucoma. In addition to the quick multiple eye pressure function of the FMD uses the eye to identify people at risk of stroke, potentially saving lives and preventing catastrophic disability. Dr. Falck, thank you for joining me today.
Thank you very much, Dr. Gelb, for the interview. It is a pleasure, and I look forward to speaking about our technology and educating individuals about what we can do to prevent blindness and stroke.
You know, Dr. Falck, I have the instrument in my office, and I have to tell you, I am so impressed and how it could help many people. I have a passion for using the eye to be able to diagnose systemic disease way early, before even internists could diagnose it, to help save lives and prevent morbidities. So we're going to get to the instrument in a little bit, but let's give the audience a little background on glaucoma. And I'm going to start with a very difficult question. What is glaucoma?
Well, basically, simplistically, glaucoma is a plumbing problem. So the eye is filled with a microscopic fluid called aqueous humor. It's a clear fluid. And the purpose of that fluid is to supply nourishment to the tissues inside the eye. So inside the eye, we have a microscopic faucet, which is called the ciliary body. And we also have a microscopic drain, which is called the trabecular meshwork. The problem with all forms of glaucoma is that the outflow system, the trabecular meshwork, the drain of the eye, is impaired. That's the fundamental cause of all types of glaucoma, except a rare type of glaucoma, which is a vascular disease, which we call normal tension glaucoma. And all the current therapy is being directed at improving the function of that drain. So again, simplistically speaking, glaucoma is a plumbing problem. The drainage system, the internal drain, the trabecular meshwork, does not work as well as it should.
So that fluid that's being made by the ciliary body, the aqueous humor, it changes with circadian rhythm. So Does it change with anything else? Does anything else, does diet affect it? Does poor sleep affect it, which may cause a circadian rhythm, stress, anything else that you could think of that may also change it, or is it basically just circadian rhythm?
That's the most common fundamental cause, Dr. Gelb. And so typically what happens, that's an important point to make, is that the output from the faucet, the ciliary body of aqueous humor, is not constant. It tends to be highest first thing when we get up in the morning on awakening. And the production of aqueous humor, that clear fluid, is driven by a hormone called cortisol. So we get up first thing in the morning, our cortisol level is rising, our endocrine system is waking up, and that's when the output of aqueous humor is greatest in the morning. And that's unfortunate when most people who have undiagnosed, untreated glaucoma have those IOP spikes, which are damaging. So what happens when aqueous humor production, the clear fluid production, goes up, if the drainage system is impaired, the eye pressure will spike because the impaired drainage system cannot handle the increased production of that clear fluid. So there are other things that may affect it, but the number one cause that we have identified thus far is the production of cortisol, which increases when we first get up in the morning.
And how about exercise? How may that affect it? Because exercise may affect cortisol or metabolic syndrome. Somebody with the big belly that has all this inflammation, if the trabecular meshwork is inflamed.
Yes, exactly. Anything that's going to negatively impact the trabecular meshwork, like inflammation. There are other different forms of glaucoma where eye produces excessive amounts of pigment, where it sheds off the iris, and those pigment particles block up the pores of that drainage system. There's another syndrome that we call exfoliation syndrome, where the lens of the eye produces these little dandruff-like particles that flake off and then block up the pores of that trabecular meshwork. And important point, Carrie, Dr. Gelb, that people with pigment dispersion syndrome, where they're releasing that pigment, that tends to increase with exercise. You get increased rubbing of the pigment off the back of the iris with the lens, and that tends to block up the pores. And people with that heavily exercise, that have the pigment dispersion syndrome, where it's releasing that pigment, the IOP tends to spike during those exercise regimens that they do.
Yeah, I've noticed people that have that have come to the office right after the gym, their pressure in their eye will spike.
Exactly. And I think, the link between, for example, diabetes that you brought up, is that diabetes in general causes dysfunction of that outflow system. The cells in that system just are not healthy. And so again, the trabecular meshwork, that drainage system, doesn't work as well as it should.
And if somebody has, speaking of diabetes or even pre-diabetes, if they have insulin resistance and the insulin is high, that also causes inflammation.
Correct. So diabetes is in fact a major risk factor for glaucoma.
One of the things that has been reported, that even despite adequate lowering of intraocular pressure, it's been reported that some people still go blind. As much as 42% could still go blind in one eye if they live long enough, and up to 16% go blind in both eyes. Why do you think that is?
Well, the issue is, I'll reference a study. So John Hopkins did a study called the Baltimore Eye Survey, and they went into the ghettos of Baltimore and studied people that were underserved in the healthcare community. And they identified about 600 individuals that had undiagnosed, untreated glaucoma. They put them in the hospital and they checked their intraocular pressure 24/7. And what they found is that the majority of people with undiagnosed, untreated glaucoma were only spiking eye pressures when they first got up in the morning, as to what we talked about. The problem is, we don't see those people in the office when they're spiking eye pressures. So when we're measuring their eye pressure in their office, that's not indicative of what the eye pressure is doing outside the office, because we're only checking the eye pressure for a brief period of time. So when we see those people who are progressing, despite when they're in our office, their intraocular pressure appears to be in their target range, it is because they're spiking eye pressure when they're outside the office. Another contributing cause, and a lot of those patients turns out to be, and we'll talk about this when we dig into the FMD device a little bit, is a lot of these patients have vascular risk factors, and they actually have impaired blood flow going into the eye. So you can have an eye which is spiking high OPs outside the office, and whenever the intraocular pressure goes up, the blood flow goes down inside the eye. It's a concept called the ocular perfusion pressure. That is, the blood flow into the eye is coming in through the central retinal artery, and that blood flow is opposed by the pressure in the eye. So the higher the pressure is inside the eye, the lower the blood flow going into the eye. And as it turns out, the optic nerve, the electrical cable that connects our eye to our brain, is a very metabolically active structure. It needs a lot of oxygen, it needs a lot of blood flow. So again, eye pressure goes up, blood flow goes down. And one of the things that we're finding, the FMD allows us to look at the blood flow going in the eye in these glaucoma patients. We're finding that a lot of these people have significant cerebral vascular disease, and so we need to be more aggressive in their treatment if they have glaucoma as well, treat the vascular disease and treat the glaucoma.
And I guess it's also a sign of overall health. You know, if somebody has poor health, they're going to have poor circulation. They're not going to be able to perfuse the nerve as well.
Correct. I think that the most amazing thing is that we as eye doctors, the eye is the only organ that you can look inside and see an artery. The only organ. Nobody else is. Look inside the eye, look at the retina. We can see the arterioles. Looking at the arterioles of the retina, we can generally assess what is the vascular status maybe of the cerebral circulation. But again, with the FMD device, we have the ability to measure the blood flow now non-invasively going into the eye. And you're right, vascular disease is a major risk factor for glaucoma, especially that we talked about previously a few minutes ago, the normal tension glaucoma variety, where it truly is a result of impaired blood flow going into the eye.
I had a retina specialist on that we just posted his podcast, Dr. Stephen Sinclair, and he talked a lot about endothelial dysfunction happening in the capillaries in the eye before the pericytes drop out. Now, if there's endothelial dysfunction in the eye, and endothelial dysfunction being a major risk factor for cardiovascular disease, eye doctors could be on the forefront of being able to diagnose who's at risk for a stroke, like your instrument does, or cardiovascular disease. Can you speak to endothelial dysfunction of the capillaries?
Yeah, so again, if we can look in the eye and look at the capillaries, and we can do studies to look at the capillaries and look at the endothelium and look at parasites, we can look at all of that. And so you're right, if there's vascular disease in the eye, that's not isolated, it's just not in the eye. That is a sign of systemic disease. So we have the ability, by looking in the eye and look at the health of the vasculature and determine what risk that person might be for a vascular event, a stroke, loss of vision, et cetera, et cetera. So we're in a perfect position to diagnose and get involved in the treatment of systemic vascular disease to prevent a vascular event from happening.
And are the blood vessels in the eye different than the blood vessels in the brain, the kidney, the toes, the heart?
The only difference between, this is just a technical thing. So when we look at an artery, arteries in general have three layers. They have the endothelial layer, they have the muscular layer, and then they have the adventitia, the outer layer. So three separate layers. The vessels that are in the eye, other than the central retinal artery, the arterioles, do not have a defined muscular layer. They lack a very well-defined muscular layer. So that's the only difference, but they are part of the arterial system. And disease of the arteries does not normally occur within the muscular layer. It occurs within the endothelial cell layer that we just talked about. You know, we have plaque and endothelial cell dysfunction.
What is the purpose of those blood vessels lacking that muscular layer?
Well, this gets a little technical. So arteries that have a muscular layer have the ability to either contract to decrease the size of the lumen to raise blood pressure, or to expand to lower blood pressure. So this is part of what we call a system called autoregulation. Getting a little bit technical here. So the retina does have some ability to autoregulate. And what that means is essentially, I'll try to digest this down. If our eye is not getting enough blood flow, the arterioles have the ability to adjust the size of their lumen somewhat, and it's a process called autoregulation. So in our retina, if the blood flow is decreased, the eye will make a compound called VEGF, vascular growth endothelial factor. VEGF induces an enzyme called nitric oxide synthase. Nitric oxide makes nitric oxide, and nitric oxide is a very potent vasodilator. So this is the autoregulatory function of the eye, where the eye can, in most states, can autoregulate. There are some disease states where that autoregulatory feature is broken.
And if we look at we talked about the vessels and we look at the nerves in the eye, now we have ways of looking at the nerves with the technology, OCT technology. So we can look at blood vessels as eye doctors, we can look at nerves as blood vessels. So at some point, we're going to be the first doctors that are going to be able to diagnose or tell if somebody's at risk for Alzheimer's disease and other types of neurodegenerative diseases. If you could speak to that a little bit.
Sure. I mean, there are lots of neurological diseases that one can diagnose, like, for example, multiple sclerosis. 75% of people with MS will present with an inflammatory condition of the optic nerve, optic neuritis. What other conditions?
Myasthenia.
Myasthenia, right, as well. So there's a whole
Parkinson's disease.
Parkinson's disease. There's a whole host of conditions because, again, when we're looking in the eye is a very complicated structure. We can see the vascular system, we can see part of the neurologic system, we can look at the optic nerve, which is a direct extension of the brain. So we can see a lot of interesting structures when we look inside the eye. And then, of course, we can see the lens and the ciliary body and the retina and all the different layers of retina. We can see the photoreceptor cells, those cells that get electrically stimulated with light, and that information gets transmitted via the optic nerve back to the visual cortex. So the visual system is, in my opinion, right? Other doctors may argue with us, Gary, but the eye, in my opinion, is the most complicated organ in the body. It does a lot of things.
I'm glad you said that, because that's something I always say. The eye is the most complicated structure in the body. And, and I know this might be blasphemy, and I'm not sure how you feel about this, but I'm going to ask you, with all these now telemedicine and people trying to do eye exams on the computer, I just feel that the eye is so complicated. How can it possibly be done today in the year 2024 adequately to be able to give somebody an adequate eye exam by telemedicine?
I am on board with that. I don't believe that that's possible. I think that's a compromised examination, because there's nothing more important than you using your eye to look in someone's eye and using your years of experience that you have by looking in that eye to see what structure is going on there. There is no ability for any device, in my opinion, to image the eye as well as the human eye can look and see inside that eye as to what's going on. So.
MacuHealth, your science-born and tested solutions for visual performance, macular degeneration, and dry eye syndrome. New products coming soon. Embrace the science.
We agree 100% on that. Let's talk about epidemiology of glaucoma. And, it's around all over the board a little bit, but they estimate there's about 3 million people in the US with glaucoma. Half of the people don't know that they have it. To me, it seems like there's many more than 3 million. I have so many glaucoma patients in my practice. Obviously, you're a glaucoma specialist, but there's a lot of people that are glaucoma suspects. And I don't know if that number is, if we know what that number is, maybe it's estimated around 10 million. What do you think about 3 million people having glaucoma in the US? To me, it seems like it's more than that, but what do you think?
I think that's an underestimate of that. And you just remember, we have an aging population, and one of the risk factors for glaucoma is age, because as we age, that little drain that we talked about inside the eye, the trabecular meshwork, becomes more dysfunctional. So one thing that happens when I talk to patients, they'll ask me the question, well, why does my trabecular meshwork not work as well as it did when I was younger? Well, the reason why is because it's aging. Within the trabecular meshwork, it's a porous system, a screen, so it looks like a screen. There are these little cells called macrophages. So we always have cells dying and new cells regenerating, and that process goes on inside of our eye. Well, all of that debris has to flow out through that trabecular meshwork. Within that trabecular meshwork, there are these little cells called macrophages. The purpose of those cells is to gobble up that debris, digest it, and break it down. Well, we know from tissue analysis that in eyes with glaucoma, most of the time those macrophages are missing. And in the case that we talked about previously, like with pigmentary glaucoma, the reason why the trabecular meshwork becomes dysfunctional is because there's so much pigment being deposited in that drain that those macrophages can't gobble it all up. So age is a major risk factor, and that's why I believe with the aging, I think right now, the last statistic I saw, I believe that we have more people over the age of 65 than under the age of 65 in the US. We have that upside down triangle. And given that basis, I believe that the 3 million is an underestimate.
Yeah,
Because as you and I both know, I believe, Carrie, that we see people all the time that have glaucoma that are undiagnosed and untreated because it's a silent thief of sight. Most people don't come to, a lot of people don't come to diagnosis early on because, you know, the diagnosis is often goes, you know, undiagnosed.
You know, and I want to get back to that, just a little bit about pigmentary glaucoma. For the audience, where does the pigment come from? The pigment is liberated. How does it get liberated? How does it get stuck in the drain of the eye?
Sure. The pigment comes off the back surface of the iris, so that colored portion of our eye that regulates the light going in our eye, our pupil, that iris structure. So interestingly enough, people with this pigment liberation, most of the time our iris is flat, but people with pigment dispersion syndrome, where that pigment's being liberated, their iris is concave. So there's increased contact of the back surface of the iris with the lens of the eye that sits right behind the iris. And so studies that we have looked at, histological or tissue studies, structurally looking, there's increased contact between the back surface of the iris where the pigment is and the surface of the lens. In essence, what's going on, there's a chafing effect that occurs with that increased contact as the pupil is dilating and contracting, rubbing on the surface of the lens, rubbing that pigment away. Those pigment granules then get dispersed in that clear fluid. The clear fluid flows out through the trabecular meshwork, the drainage system. And again, those microscopic particles block up those pores. And when you look at an eye, there's a special lens we can put on an eye called a gonioscopic lens. It allows us to look directly at that trabecular meshwork. And when you look at an eye that has pigment dispersion, there's a very dense pigment you can see in the trabecular meshwork, lots and lots of dark pigment deposited there. So nobody's been able to answer the question, though, good explanation as to why these people with the iris, why it bows backwards, why it's concave instead of flat.
And it's kind of easy to look at the mechanism of pigmentary glaucoma, and you kind of alluded to the mechanism of open angle glaucoma, which is the common type of glaucoma that we see. The most common in the United States is the open angle type glaucoma. Do we know what the mechanism of that is?
Yes, it's impaired outflow of aqueous humor. The trabecular meshwork becomes dysfunctional. The macrophages are gone. So the reason why we call it the trabecular meshwork is because there are these little beams called trabeculum. And what happens with POAG, the most common type of glaucoma, the trabeculum thickens, the macrophages go away. So we have this increased buildup of the debris within it, normal cellular turnover of debris, and the pores get smaller. But fortunately, we have very effective treatment. We have drugs that can help the trabecular meshwork, the drain, work better. We have lasers that we can do to make it work better. And in cases where patients with very advanced glaucoma, where the medical therapy has not worked or the laser therapy has not worked, we have the ability to put little stents in the eye to bypass the drainage system. So we have very effective treatment for treating glaucoma. There's no question. And there's no need, in my mind, that with the proper treatment, a person should go blind from glaucoma. But the key is early diagnosis and early treatment.
And we're going to get into the treatments and early diagnosis with some of the new technology like you've developed. I want to ask you about narrow glaucoma. Most, it's funny in school, and I'm not sure when you went, if it was the same when you went to school, probably around the same time as me. We were taught that there is no symptoms for glaucoma, but if someone has narrow glaucoma, I've seen many patients who have been from doctor to doctor, internist, for headaches, pain around their eye, for being treated for sinus problems, being treated for different types of headaches. And it turns out they have a narrow type of glaucoma that's causing eye pain around the eye. And a little treatment with a little puncture with a laser in the iris, the headache goes away. And they've come in with cookies for me, and they come in with cakes, thanking me because they've been suffering with headaches for 5 years. And now with a little tiny treatment, they were able to solve their headache problem. Can you talk about chronic angle closure, the different types, the different progressions of angle closure, glaucoma?
Sure. So with angle closure glaucoma, we had talked about, like with pigmentary, how the iris is concave. Normal iris configuration, for most people, the iris is going to be flat. With narrow angles, people have a condition which is called iris bombay, where the iris actually bows forward. Bombay in Latin means bowing forward. So because the drainage system of the eye is located in an angle between the window pane of the eye and the peripheral iris, the very edge of the iris, the farthest away from the pupil. So if someone has an iris which is bowing forward, that will cause the angle, the drainage angle where the trabecular meshwork is, to become narrow. In most eyes, where the iris is flat, the trabecular meshwork, the angle will be at about a 45-degree angle. That's what we call an open angle. If somebody has iris bombay, that angle will be very shallow and very narrow. And the greater the bombay, the greater the bowing forward of the bombay, the narrower the angle will be. Now, in people that have narrow angles due to iris bombay, when the pupil dilates, the angle closes off, the aqueous humor, that clear fluid, does not get access to the drain. The ciliary body, the faucet of the eye, does not stop making fluid, so the fluid cannot get out of the eye, and the eye pressure rises rapidly. And when we get that severe of pain, typically people with angle closure, when they present, the eye pressure will be 50, 60 millimeters of mercury. The eye is as hard as a golf ball. That pain gets referred to their forehead, and they will come in, or they'll wake up at night with a pain over their forehead. Interesting case that I saw early in my career of a poor woman who actually was unable to sleep at night because she would literally, the pattern was, she would go to bed, and she had not been previously diagnosed with a narrow angle. She'd go to bed, she would wake up an hour after going to sleep with an intense headache over her right eye. The first thing she did was she would turn the light on, and the headache went away. Because when she turned the light on, her pupil constricted, that pulled the iris away from the drain of the eye and opened it up, and her headache went away. But the poor lady could never sleep at night. So one night she got up, right, with this headache, turned the light on, the headache did not go away. And she went to the emergency room because on a scale of 1 to 10, this headache was a 10. She went to the emergency room, and astutely, the emergency room doctor diagnosed her with angle closure glaucoma. And she was simply treated by making a little microscopic, non-invasive laser incision in her iris to open up her drainage angle, and then she could live a normal life and sleep. Why did it happen when she would go to bed? Because People that have a narrow angle, when we close our eye, the pupil dilates during non-REM sleep. So during non-REM sleep, right, non-dream sleep, our pupil dilates because our eyelid is covering the pupil. In REM sleep, our pupil constricts. So that's what happens. But people that have these narrow angles, when they're in non-REM sleep, they're at risk of going into closure. But a very, very easy diagnosis to do. Again, we as eye doctors, when we look at someone's eye, we're looking to see, is their iris concave? Is it bowing backwards? Is the iris flat? Does the iris bow forward? And there are certain, so if we look at iris Bombay, okay, now we have to talk a little bit about race. So if we look at iris Bombay, only about 10% of Caucasian eyes have iris Bombay. But if you look at Asian eyes, 90% of Asian eyes will have iris Bombay. Alaskan Inuits, 90% of those eyes have iris Bombay. So we know when we see those individuals, we're looking to see if they have iris Bombay, is their angle occludable? How shallow is that angle relative to 45 degrees? Typically, what I've seen in my practice over the years, if someone has an angle which is less than 10 degrees, they're at risk of going into closure. So I will offer them, there's a drop we can use, but it's a miserable medication called pilocarpine. It constricts the pupil, prevents the pupil from dilating, will stop them from going into angle closure, but it blurs their vision. The recommended treatment, as Dr. Gelb described, is to use a laser, make a microscopic opening in the edge of the iris, and that ensures that that angle won't go into closure.
And this is something that's very easy for an eye doctor to see in an office, not easy to see on a computer exam.
Nope, you could never do gonioscopy on a computer exam, Kerry. You're absolutely 100% correct. I am not a fan of telemedicine. I don't even think telemedicine is good for primary care doctors because you're not measuring a patient's blood pressure. There's something about a face-to-face interaction, and especially for us, using our eye to look at someone else's eye, because as we're doing that, we're applying years of experience, years of knowledge. We've seen a lot of these situations before. There's nothing better than face-to-face contact, in my opinion.
Let's talk. You mentioned a little bit about risk factors and age being a risk factor for glaucoma, but let's talk about some of the other ones that people may not think about, such as like sleep apnea or migraines, being very, very nearsighted. But talk about some of those.
Sure. Well, as it turns out with sleep apnea, so with sleep apnea, people will go to sleep and they have a obstructive airway, and what happens, why that is a risk factor for glaucoma, this gets into blood flow. People with sleep apnea, their O2 saturation drops in their bloodstream. And again, we talked about the fact originally that the optic nerve, that electrical cable that connects our eye with our brain, is very metabolically active. Just think about the fact of how your eye actually works. Light goes into your eye, stimulates the photoreceptor cells, the rods and cones. They generate an electrical signal. Each rod and cone is hooked to this little tiny electrical cable called an axon, little tiny electrical cable. Millions of axons make up the optic nerve. That goes back to our cerebral cortex, our computer at the back of our head, and all this visual information is being processed. So your optic nerve is doing this billions of times a second. I mean, it's processing billions of bits of information. And so it's very metabolically active. So in sleep apnea, when the oxygen saturation drops because the airway is obstructed, they're not moving enough air, that can present, that's a major risk factor if a patient has glaucoma, for the optic nerve to become atrophic, for those axons to die because they're not getting enough oxygen. So decreased blood flow is a major risk factor for glaucoma progression.
And you talked before about normal tension glaucoma, where people have glaucoma, but their eye pressure isn't high. And people with sleep apnea have like a 10 times risk of having normal tension glaucoma. And they could also have little hemorrhages in the eye and on the nerve of the eye. Can you talk a little bit about that?
Sure. Again, what it has to do with decreased blood flow. And this entity that we talked about, just a brief mention. So one of the things that the FMD device, the Falck Medical Technology, has the ability to do is to measure the blood flow going in the eye. Our eye derives its blood flow directly off the internal carotid artery. So if there's disease in the internal carotid or the external carotid artery, that's going to affect the blood flow going in the eye. Recently, the FMD technology, it does a test called optodynamometry. It measures the blood flow going in the eye. And this individual in her right eye had very, very low blood flow going into the right eye. So the doctor ordered two additional tests. One test was called the transcranial Doppler test. These are ultrasound tests that measure blood flow. They're non-invasive tests, and they can measure blood flow through the cerebral vessels, the vessels above our jawline, all those vessels, and the vessel below our jawline. Lo and behold, the reason why she had a pale optic nerve, not well perfused, progressive optic atrophy, but always had normal eye pressure on multiple visits, and always had a normal functioning trabecular meshwork. The drainage system of her eye was working correctly. And she would also talk about these intermittent episodes where there would be temporary loss of vision for a few seconds. The vision would go gray. Long story short, the ODM, the optodynamometry, was abnormal. And on the transcranial Doppler test, the radiologist noted that there was backwards flow in the ophthalmic artery, that blood flow was being pulled away from her right eye. And the reason for that is because she had a major stenosis, a major narrowing of her internal carotid artery. So the blood flow was being robbed from her eye and shifted to other parts of her brain. So she was treated, the stenosis was treated, and everything was restored, and she was prevented from going blind. And that is like what we would call a case of normal tension glaucoma, where she had visual field loss, but her blood flow was impaired going into her eye. And these cases of normal tension glaucoma, it's impaired flow of blood going into the eye, which happens in sleep apnea. The blood flow, the O2 saturation goes down. The person is not breathing adequately, and the eye is being deprived the optic nerve of blood flow.
And if we could back up just for a second, we're going to go heavily into this later on in the podcast, but we have the carotid artery, and it branches off into the external and the internal carotid artery, and then the internal carotid artery goes to the ophthalmic artery, and then we go up, and then there's the circle of Willis. So there's all these different pathways of the blood vessels that feed the eye and feed part of the brain. So I just want people to kind of have what the anatomy is so they can kind of understand what's happening, because it gets complicated.
Correct. Yeah, so we have, and as it turns out, so most of the time if somebody has risk factors for a stroke, the test that's routinely done is just the external carotid artery, called the carotid duplex scan. But we also need to look above the jawline and do a test called the transcranial Doppler test to see what's going on above the jawline. Because as we talked about before, if we look in the back of someone's eye and we see that there's evidence of vascular disease, we see narrowing of the arteries of the eye. And when we say narrowing the arteries of the eye, again, and this is something that you would not see with telemedicine, Carrie. When we see a narrowing an artery of an eye, we shine a light in the eye, we call it silver wiring, because the vessel is narrowed and it will look like a silver wire. So it's reflecting the light of our instrument. You can't see that on telemedicine. You can only see that when you look in the eye. And that's a sign that that vessel is narrowed in a process we call sclerosis. Well, if that arteriole is narrowed, that artery is narrowed, that's a sign of cerebral vascular disease. So we need to look a lot further. So again, my opinion, eye care providers can be the first individual to look in an eye and recommend interventions and further studies to prevent someone from going blind due to vascular disease or having a stroke.
Let me go back to the silver wire and the increased reflex that we see. Is that I mean, before it even becomes to the point where the sclerosis, first we get the anatomy down first. First we have endothelial dysfunction, then we lose parasites, then are we starting to lay down plaque, and then are we seeing silver wire? Is that how it works?
Yeah, when we have the endothelial, we get the endothelial dysfunction is going to happen first, and then we start laying down plaque. And then we start losing parasites. So now we have a vessel which is structurally abnormal. And that's essentially what happens. And when that vessel becomes narrowed, which we call sclerosis, right, or stenosis, that's when we see the silver wiring effect. So we're actually seeing silver wiring. That's a fairly advanced disease state.
And at that point, we could be working with the cardiologist or the neurologist to see if there's any risk factor for a heart attack or stroke.
Exactly. At that time, so that's why you become part of that healthcare team with the cardiologist, the primary care doctor, the vascular specialist. So you're part of that team because, again, the eye is the only organ you can look into and directly see blood vessels. Only one. And the other thing I'd mention, Carrie, is that the importance of this is if you look at this, so we have the external carotid, we have the internal carotid, we have this circle of Willis that connects everything on both sides, and we have the ophthalmic artery coming off the internal carotid, the distal end of it. The eye is the end organ in that vascular system. So anything going on in this vascular system, which is not normal, puts the eye at risk.
And if the optodynamometry test, which we're going to talk about later, is abnormal on the instrument that you've developed, there's a 78% chance, that somebody's at risk for a stroke.
Correct. So if you look at, we've done a prospective study, we've looked at the optodynamometry, the ODM test. If that test is abnormal, that test detects that the pressure in the central retinal artery is reduced. That's a sign of narrowing someplace in the vascular system. If the ODM test is abnormal, there's a 77.7% probability that there's an abnormality someplace in the cerebral vascular system or the external carotid.
Your eyes and your vision are under attack. Damaging blue light from the sun, your phone, your computer, your tablet, even light bulbs and car headlights is constantly bombarding you. The good news is our eyes actually already have a line of defense to counter the effects of blue light. This defense is made up of 3 pigments called carotenoids. MacuHealth with Micromicelle, the only supplement with the exclusive patent on all 3 macular carotenoids and Micromicelle technology.
Fitting multifocal contact lenses presents a big opportunity to meet patient needs while growing your practice. Alcon is your partner not only with our innovative portfolio, but through e-learning. Learn to enhance your multifocal strategy today with the Alcon Experience Academy.
OIE Broadcasting is the emerging leader in social media. We use scientific entertainment to drive more patients into your office. Visit oiebroadcasting.com and sign up today.